Hi, vet rehabbers, and welcome to another Facebook Live this week with Dr. Michele Broadhurst. Welcome, Dr. Michele.
Thank you, Renee.
Would you introduce yourself to us, please, and tell us a little bit about where you're from and how you got into rehab? And then I'm going to check that our audio is working. If you guys can hear us, pop a thumbs up. Let us know that you're here with us.
Sure. So I am a certified animal and human chiropractor. I had a practice in Cape Town, South Africa for about 15 years and specializing in small animals and equines. And we moved to the US at the end of 2017, beginning of 2018. And we kind of continued our journey. So we were initially in Maine and now we're in Colorado. So I have a little bit of a mixed bag background. I'm a acupuncturist as well as a CCRP. And what else am I? And I'm a certified international chiropractic sports physician. So I wear a number of hats and I have always loved animals. And so back in 2004, 2005, I decided, see, that's how old I am. I decided to diversify in my practice. So I came over to the United States and I studied at Options for Animals, which is a animal chiropractic school, and then certified with the International Veterinary Chiropractic Association. And then it just grew really, really quickly and really organically. And my practice really focused on dealing with functional and structural pain together, both on a human level, and then it really translated right the way across into the animals. And I found it the most amazing combination when we're looking at treatment to really treat holistically and treat everything that's going on, not just things that are going on a structural level. So that's my story.
I love it. I love that you're from South Africa.
Can the accent tell?
Yeah, and I'd love to add to your, to your list of things that you are. I think you're the OPH team's favorite nerd. So
I'm never called a nerd. That's amazing.
You're our favorite, for sure, for sure. So it looks like everything's good. Welcome to all of our listeners, everyone watching out there. If you're with us, please let us know where you are, where you're listening from, and what you're doing. And if you have any questions, so we're going to be chatting about the link between pain and structural and functional dysfunction. If there are any questions, pop them in the comments. I can see them nicely here, so we'll answer those as we go. So I would like to just mention before we get started, if you guys are not familiar with Dr. Michele's book, Ali, please pop that link into the comments. It's a fantastic book on understanding myofascial pain in our canine patients, and she's recently released the equine one, but we'll just pop the small animal one in there for you guys. So if you haven't started reading it yet, do it. It's my bedtime reading right now. So and then Dr. Michele's also lecturing for us at the Vet Rehab Summit this year, where she's going to be diving deeply into these topics that are so integral to her. So join us for that as well. So now I would like to ask, you chose this topic, Michele. Why did you want to specifically speak about pain and structural and functional dysfunction?
Okay, so this is something that I am very passionate about. And the reason being is that I feel very blessed that I've been able to be in this industry for such a long time. I've been doing it for almost 2 decades. And one of the things that I seem to be coming across more and more is the very isolated view that clinicians are having right now. So it's like, oh, the dog's coming in with a post-TPLO, or it's got a CCL. Okay, so what do? We focus right in on that knee and that stifle. But what we're not actually understanding are the pain pathways that are associated with that. So we do ranges of motion around the knee, and we're like, oh, this is stiff, and that's not working, and hamstrings are tight. Okay, cool. So we're just going to treat this thing. But what we're not actually taking into account is the actual pain pathways that are so integral to allowing anything to work optimally.
Mm,
So when we're looking at ascending and descending pain pathways, the way that the alpha delta and the C fiber nerves communicate with the anterior cingulate cortex in your brain
mm,
is so very important as to how our outcome is going to be. And what
mhm,
I find so often is that we're not actually addressing the mechanisms of pain, functionality, and structural in one whole thing. So,
mhm.
for example, when we look at descending pain pathways and we're looking at and I always stutter over this word, so I apologize, androgenergic. I can't say it for the life of me. Anyway, when we're getting like serotonin, enkephalin, and all of these different hormonal releases, which really help to change the action potential that's happening on a neural level and change the outcome of the pain pathway. So I always
Mhm,
explain when I lecture about this that it's like playing broken telephone, right? Is you want to have that connection. So with a cell phone signal, it's super fast, it's very efficient, it goes where it needs to. Pain is a little bit like playing broken telephone, that we get this static kind of weird communication that can escalate as it goes down the chain.
mm,
And we actually need to start addressing pain at a very deep level so that we can actually change the functional and the structural stuff that's going on. And one of the ways we really need to look at that is by treating not only the issue that is presenting, like let's say a stifle, but we need to
mm,
start looking at everything else. Let's look at the diagonal that's being affected. So, how is that teres muscle, that lat dorsi muscle handling? How is that? Where's that shoulder? Where's that scapula sitting? Because now it's cranially loading, right? So now
mm,
we've got to start looking at other stuff that is inhibiting the recovery of that animal and get away. Obviously, we're going to treat the initial issue, but we've got
mm,
to start looking at things on a much more integrated level so that we can get the optimization a lot faster, a lot more efficiently,
mm,
and get that animal out of pain very quickly. Because
mm,
if we're always just focusing, we've got those blinkers on, looking at that one issue, we're actually not doing that animal justice.
mm. Okay, so I'm going to try and say what I've understood from what you've said.
Mm-hmm.
Okay, so basically, what we need to do is we need to understand pain at a deeper level. We need to understand
Mm-hmm.
what it's doing through the spinal cord, from the peripheral nerves through to the central nervous system into the brain. And we need to make sure that we're addressing pain in all the ways that we can. So if we have like so obviously our pain is not coming from only the condition, the primary
Mm-hmm.
condition that the dog is suffering from, but also from secondary compensations. And we have to find those and make sure that we're addressing those. And I'm assuming that we're going to be doing that both in our treatments as well as medically when we need to add, additional pain medications to that. So am I on the right
Spot
track?
on.
Spot
Absolutely.
on. Okay. Not focusing on one thing, making sure that you look at the dog holistically. So now you've spoken to us about pain. So break down for me, what are you talking about when you say structural dysfunction?
So one of the big things in veterinary medicine is, for the longest time, everything was a joint. you
Mm,
know, and it's always like, oh, it's a joint issue. Oh, it's a joint issue. Oh, it's a joint issue. And we're like, well, there's these very cool things that surround joints, and they can also be a little dinky at times. We should totally look at them. Uh, so when I'm saying structural stuff, I am talking about on a bone level, on a joint level, all those different things. So, when I got into this, before rehab was even a thing, really, that was one of the things I always came up with. And especially in the equine world, it's like, let's block that joint. Let's go. Block the joint, block the
mm,
joint, can't be anything but the joint. And joints are obviously very integral and can be incredibly painful. And especially when they're not moving optimally, it does create obviously a neurological cascade and issues like that. But, for the longest time, it was always like, oh, well, it's hip dysplasia. Okay, but you know that there's like capsules, there's ligaments, There's all this other stuff that surrounds it that are
Mm.
highly innervated by nociceptors and mechanoreceptors that again feed that neural pathway and the pain pathway. So, looking at things as an individual issue just didn't ever make sense to me because it's never just one issue. So, structurally, we're talking about bones, joints, and all the hard stuff in our body.
Okay, cool. So essentially our anatomy,
Mm-hmm.
also a little bit kind of how those pieces are fitting together.
Yep.
So in terms
Articulation.
of like
Mm-hmm.
conformational
Mm-hmm.
and I'm thinking specifically changes that are going to occur. Like in dogs, we'll often have changes in angulation, right? When we have
Correct.
pain for anything,
Mm-hmm.
and especially when that becomes chronic. So is that I'm on the right track there?
Absolutely. So, like, if we're looking at the vertebral system, like spondylosis makes a huge, huge difference, right?
Mm.
So, when we're having spondylosis occur, or we're having any sort of calcification in a joint or osteophytic formation, things like that, it definitely changes the way that the biomechanics work. So, we have to take that into consideration. And especially if we're looking at things spinally, we've got to remember that neurologically, the joint that is being affected. So let's say we've got an L3 that is really spondylitic. It's got an accumulation of bone growth. It's nasty. If you look at it on an X-ray, it looks like someone's drawn outside the lines. Um, that's the way I look at it. I'm like, oh, messy kid. And you've got all the spondylosis going on and the sclerosis in the joint. Now, what's happening? That joint is inflamed. The body's putting down more bone to try to compensate and create better integrity. But now all of a sudden, that little IVF that allows the nerves and the blood vessels through, it no longer has the integrity that it had before. And that's when you need to go into a neural level and go, okay, cool. So this nerve that is affecting the L3 also has a trajectory nerve that goes to the levels above and below it, right?
Mm-hmm.
So, what dysfunction is going to be happening at that level? So, yes, we may not be able to completely change this joint. Let's see how much mobility we can get so that we can increase ranges of motion, decrease pain, all the things that we're trying to achieve in rehab. But we also have to look a little bit further up and down because we know that those accessory nerves are going to be affecting things higher and lower.
Mm. Okay, I like it. It's making me think very much in terms of like we always want to be specific, right? It doesn't help we just go in and we just treat our patients and just
Randomly.
love on them. That's just not, we need to be very
Yeah.
specific with what we're doing. And the better our understanding is of the integrations of the body, the connections of the body, and how everything works together, the easier it is for us to see to think of the things that could be affected and then to find them, right?
Absolutely. And I think always having a differential in your mind is very, very important. So
Mm.
the way that I treat, even if something is clear cut, I'm always like, okay, what else is being affected? What else could be presenting in this manner that we're not looking for? I always got taught as a student back in the 90s, so old, that when you hear hooves, don't, look for horses, but they could be zebra. So you've got to remember that it's not always what you always think it is. Sometimes you've got to look a little bit broader to encapsulate other things.
Okay, great. So we've chatted about pain and structural dysfunction. What are you saying when you say functional dysfunction?
Okay, so like we were talking about functional stuff as far as like, let's just, muscles, ligaments, tendons, capsules, burses, you name it, anything that isn't hard and bony is really functional. And
Okay.
I include in that very much neurology as well as blood flow. Because one of the things that we have ignored significantly, both in the human and in the animal world, is the importance of vascularity in accordance to proper functionality. So, especially since I started working with fascia, and as a lot of you know, I'm very passionate about fascia and muscle and the way that they work together. When we don't have something that is getting the correct blood flow, we have the same issue almost as if we to a slightly lesser degree because vascularity can change. So it can actually recreate, with angiogenesis, you can actually change the blood flow. You can get tributaries being created, and the body's really smart because it allows that blood to go like a stream to other places. So, but it's one of the things we really do ignore. And I've been finding more and more in practice that that's become a bigger issue than what we ever thought. So we need to stop just always looking like muscle. It was muscle, 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 muscle for the longest of time. And what we didn't even realize about fascia is that fascia creates ligaments, tendons, capsules. Who knew, right? And because it was always like, oh, your tendon creates force, it transmits the force that when a muscle contracts, that goes onto the tendon. Well, now we know that actually that's not theoretically right. So when a muscle contracts, actually between 30 to 40% of that contractibility goes onto the fascia. So we cannot ignore the relationships between all of these things that work on an optimal level to make us healthy. So when we have, for example, fascial dysfunction, and it starts getting knobbly and hard, and it creates all these little road bumps, basically we're changing the nutritional component of our bodies because fascia allows for blood flow, lymphatic flow, and neurological flow to be efficient. So when we have blockages in that system, we're actually changing everything right the way through. So again, it comes down to not always just focusing on that stifle. So say we've got super, super bad scar tissue happening in that stifle. We've got a nasty little medial effusion. Everything's kind of going to pot a little bit in that joint. What's going to happen? It's going to actually change the entire biomechanics of the fascia. It's going to change the muscle compensation in other places. Nutritionally, we're not getting the toxic removal that we should have because the lymphatic system is not draining. When, all of these things come into play, and that's what functionality is. It's not looking at just one component. We've got to look at everything because if we're not getting that area to optimize and work at a high level, we're having issues somewhere else. I can almost guarantee it.
Okay, this is very cool. And I'm thinking now, and I've come to realize in the last weeks, like as a student, I was focused on the things that I could really affect, right? So joints and muscles and tendons and understanding those, and let me just like get a really good grasp on those. And in the last few weeks, I've come to realize, but I kind of don't know my neurological pathways and my blood flow pathways nearly as well as I should. And without that, those are integral to our movement, to our function, to our structure as well. And if I don't have that knowledge, I am falling short. So
Yay for you,
so I'm glad that I'm getting I'm on that pathway now, and starting to learn a little bit about or learning why I should know them so that I can go study them. The why is always so important. So, and I mean, this is all coming from me from the fact that like learning about how connected the body is, that is just, it's just so exciting. It's so exciting.
Yep.
So let's chat about some examples now, because I really want to kind of bring these three areas together for us so that we can understand in a practical way. So if you're evaluating, right, how are you thinking about the connection between pain, structure, and function, and what are you seeing? Give us some kind of case examples so that we can understand.
Forward. Okay. So let's take some common stuff. For example, okay, let's take a dog with back pain. We all have them, right? Always. So let's say it's a lumbar spine issue. We know that there's sclerosis. There's a possible IVDD. And if it's not and I'm a little bit funny about IVDDs because it's not enough for me to classify, because it could actually be a compression where we're, is it a bulge? Is it an annular tear? Where are we as far as IVDD goes? Because I think that's really important to your outcome. In older dogs, it's really that we've got a dehydrated disc, so we just don't have the full functionality, which changes the IVF's integrity. Okay, so just putting it out there. Okay, so let's say we have got a 14-year-old dog, presents with back pain, comes in very roached, hyperkyphotic, not extending its hips and hindquarter. There's very little propulsion through the pelvis, heavily cranially loading, because that's the only way it's able to function. Let's just give that as a presentation, okay? Where are you going to go first? Probably you're going to go to range of motion, right? And check to see what's going on. So let's say we do range of motion, we stressing the spine, trying to see how much movement there is. There's hypermobility at several segments. So let's say upper thoracics are really tight between T4 to 6, because that's where the cranial loading is coming from. We have changes at T13L1 because that's the thoracolumbar junction. And that disc that's affecting is sitting at around L2, L3. Okay. Great. Okay, so we know what's happening on a spinal hypermobility level. What's happening in that elbow? Because every time that dog is cranially loading, what is it doing? It's pulling through, it's locking up its scapula a lot of the time because it's having to draw, and it's putting immense strain on that elbow. So let's look at the elbow. Okay, let's look at the tarsi behind. So now we're not getting that propulsion. What's actually going on? So we know we've lost hip extension, right? So cool. No hip extension, hyperkyphotic, doing this piston type of action. Okay, so are the tarsi dropping? Maybe, because where are we getting the pressure now? In that hind limb. Okay, because we're not extending the hip. So we're getting this piston type action on these poor little joints that are not designed to be smashed on. They're supposed to roll, right? But we got no roll. So what happens when we don't roll? We smash. So we're getting this little impact on these tarsi. So they start to have ligamentous integrity issues. So they start to see hyperextension through the tarsi. Okay. The knee on the medial aspect starts to load a little bit more. So we start seeing a little bit of an effusion on the medial aspect of the stifle. We start to see iliopsoas and the adductors getting super tight because of the lack of hip extension. We start seeing gluteal atrophy because we're not getting that full hip extension anymore. And we're getting this hyperkyphotic spine that is pulling those sacroiliac joints into an abnormal position, so they're not able to roll, right? And go into flexion and extension. So we're not engaging core anymore. Those iliocostalis muscles are as big as Rocky Balboa because they are compensating for the multifidi muscles because of the instability in the spine. So we're getting these rock hard QLs and iliocostalis. The lumborums are coming to the party too. They're not happy either. And then we're going to look onto the front limbs. So what are we going to look on the forelimbs? We're going to look for, is there a bicep tendinopathy from the constant pulling? Because poor little bicep takes up a huge amount of strain. How's those lats doing? Because now we're not getting that proper shoulder movement either. So I often find that tricep and lat is now an issue. First ribs often are a problem because of the constant cranial loading. Lower cervicals start locking up because when you're hyperkyphotic through your spine, you can't raise your head. It's really hard. Okay, so we start getting shortening of the cervical spine. We start getting SCM and scalene shortening here. We get overloading of the posterior cervical muscles. And so what do we treat?
Hi, everyone. I'm so sorry. We're back. Can you hear me, Michele?
Oh, yeah, I can hear you.
Yes. Okay, great. Okay, perfect. So yeah, we ended on a cliffhanger there. So you've just described essentially a very overwhelming picture, right? That's kind of where we are because there are so many things involved there that it's kind of like, where do we even start? So where do we start, and how do we take this whole picture and make it a little bit less overwhelming, not just for us? How do we present that to our owners and then get to the other side?
So I think the most important thing from my perspective, and I can only offer you what I know to work for me, is I always do start with a neurological and a structural component, because until we start to change things on a structural and a neurological level, we're always going to get functional compensations. So for me, I always work on trying to create increased or optimal mobility in a joint, so that we can get correct neurological flow, because that's really what we want. We want the host pipe to reach all the way to the flowers. So without that proper neurological flow, we are not going to get optimization of the body. So changing the structure is important. Changing the neurology is obviously very important. And then I really pick my primary compensations. So my question to myself is always, okay, even if we can't fix this in its entirety, how are we going to be able to allow this dog to move? So with something like a degenerative spine, that's going to keep on coming back up and up and up. But we need to make sure that the compensations that are put in place are able to allow this dog a certain level of functionality and a decent quality of life. So what I always look at, let's say it's a first treatment, I would adjust the hypermobile areas. I would do passive and ranges of motion, just because that works on a structural and functional level. Really look at the neurological component, and then do some soft tissue treatments on, let's say, tricep, teres, bicep, glute medius, because we need glute medius to fire in order to get the hips to work more effectively. And I'd work on that iliocostalis.
Okay, so that broke it down a little bit. So starting with the neurological system, that is the beginning. I like it.
Yep. Yeah. So neurology, structure, function.
Okay. Do you use, we chatted last week about the use of a problem list, which can be really helpful to take to, I want to say to simplify, but it's really to take that feeling of overwhelm and where do we start and help you to focus it. Do you use a problem list?
I definitely have a way of doing it myself. Yes, absolutely. So I think it's very important to we see so many patients so often that sometimes we forget the stuff that we've forgotten. So it's really important to have a problem list and have a list of differentials, because my rule of thumb is generally I want to see some sort of change in 3 days, in 3 treatments. So if I'm not seeing that, I need to relook my treatment protocol and my diagnostics as well as my differentials, so that I can be in a position where I know I'm best treating this dog.
Okay. How do you present this information to an owner? How do you chat to them about this extreme connectedness of the body and take their initial diagnosis of a cruciate rupture and show them that it's actually so much more without overwhelming them?
So I'm a little bit of a storyteller with my patients. I use a lot, as you know, you've seen me lecture, I use a lot of analogies, and I really try to dumb it down to them. So, for example, I talk to them about a pebble in their shoe. So let's say you have a stone in your shoe, right? All you can think about is that stone in your shoe. And what starts to happen? Initially, it's not that much of a problem. But then as you're walking through the mountains and you've done a couple of miles or kilometers, that pebble starts to feel like a huge boulder in your shoe. You start developing a blister, you're walking funny. All of a sudden, your opposite shoulder starts to hurt because you're dropping onto the other side. And so by the time you come home after a 5-mile walk, which is normally nothing, you're exhausted and you're in enormous amounts of pain in all different parts of your body because you've been compensating, right? And then they go, oh, yeah, I know what that means. And I think that's really important is you can't you really have to make this a viable thing for a client, because when you start getting technical, I don't talk about pain pathways like I do with you guys. I talk about hose pipes and nerves not getting to, and your flowers are dying. Now, why are they dying? Because your foot's on the hose pipe, or you've got a kink in the hose pipe. So you've put the hose pipe on, which is your central nervous system, and the water is running, but when it gets to that kink in the hose pipe, it stops going where it needs to go. So you're very fastidiously watering your flowers, but it's not getting where it has to go, and the flowers die.
I love that. And I want to hear more of these.
I've got lots.
What else do you tell your owners?
So, like when we're talking about adhesions, myofascial trigger points, things like that, I always equate it to an elastic band and the integrity of an elastic band before it snaps. So, an elastic band is designed to expand and come back to its normal size. So, like Wolff's law, right? Of deformation. So when we're using an elastic band, and we use it a lot, and sometimes that integrity changes and that elastic band can snap, but you still need the elastic band, right? So you tie a knot in it, but now it's weaker at the knot. So it snaps again, and then we tie another knot and maybe another knot. And every time we tie a knot, that elastic band is getting shorter and shorter, and the integrity of the band changes. And everybody goes, oh my God, I totally get that. That's how I teach them.
I love that. Okay, I like that. I have to say, I just have a big bag of elastic bands and I just take out a new one.
Not for the point of illustration, Anae. Just go with the analogy. Go with the analogy. But
I like
yeah,
it.
you have to, you got to realize how little your clients know. They may be very
Yeah.
educated people in their choice of work, but it's our job to make them understand why their dog can't run 5 miles 4 weeks after a TPLO, and that it's okay, and that this is what we're doing. And if we don't do that with clients, and we don't make it applicable to something in their life that they can relate to, they're never going to get it. They're not meant to know cruciate anatomy. It's not their deal. It's our deal. That's why they pay us. But we need to be better at getting that level of understanding. And like DM dogs, I talk a lot about neurology and cell phone signals, and how for a DM dog, you're in a tunnel all the time. And that cell phone signal is so choppy because it's not actually articulating. We're not getting that proper flow like you're in a field, right? And then they go, oh my gosh, that completely explains why he falls down when he turns the corner. I'm like, yeah, he's in a tunnel, dude.
That's really brilliant. And I mean, I know as an owner as well, you just like, I will not understand anything that you say to me if you speak to me like I'm a professional when I come to you with my sick dog. It just, my brain just it can't handle it.
Well, and you've got to remember too that you're an emotional person when your animal's sick, or there's something going on and you love this animals as much as, probably more than your spouse. And all of a sudden, this is not working. And you're like, what is happening? And somebody goes, well, let me explain to you. So we have a nerve root entrapment at L3 that's resulting in a lack of ability for this and this muscle to articulate. And they're going, why are you swearing at me? I just asked a question. But when you can say to them, okay, you know how it is if you go through a tunnel and your cell phone signal goes all a bit crappy? And they're like, yeah. I'm like, that's what's happening. And then they're like, oh, okay, I get it. So you have to make it real. You have to make it so that they understand, because you're asking them for compliance at a treatment level. How are they going to comply when they don't get it? They have to get it. They have to understand, because if they don't, you've lost the patient and you've lost the client.
We have a listener that says that they used the elastic band analogy with a client today. So
good job.
That's obviously a good one.
Yeah, I love it. I use it all the time.
Yeah, it is so important. Like we often want to focus on owner education because we want them to understand and to know
Yeah.
what's happening with their dog. But it's kind of like I have this feeling that I don't want information in my head that isn't going to help me with my life, because
Mm-hmm.
then I can't have information in my head that will.
Yeah.
So like if you start talking to me about my cars, this and that, I don't care.
No.
Like, I don't
No.
want to learn it. I don't want to know. I care about my car. It needs to run,
Yeah.
and it
It's got to
needs
be
to run
safe.
well, but I don't want to know about the insides,
The trouble
which
is,
is,
yeah, the trouble is in rehab, we can't see these animals every day.
yeah.
And there's an amazing tools out there that can help him up harnesses, booties, all these different things that will help with weakness and dysfunction. But if the clients don't know about this and they're not able to understand the entirety of something, then they can't equate that to their dog. They're like, the
Mm.
exercises, they're really not showing a huge amount of difference. And I'm like, did
Mm.
you go to the gym and get buff in one day? I don't think so, buddy. Like, you got to keep working at it, and you've got to make it applicable to them, because let's be honest, human beings, we're very selfish. So we're very
Yeah.
self-absorbed. So it's got to resonate with our own story. Um,
Yes.
and that's the most important takeaway, is like, it's got to resonate with your story. So, and that's
Mm.
why I used the pebble in the shoe. And I was like, you want to know how your dog's feeling with its sore knee? Put a big stone in your shoe and walk around for a day. Then you'll have a great idea. Seriously, do it. I've had a patient who actually did that. So I said to them, I
Really?
said, yeah, I said, because he's like, I don't get it. Like, my dog's like 6 weeks post TPLO. He should be running. So I'm like, cool, come outside. And I put a pebble in his shoe and I said, walk around with this all day. See how you feel. And he actually did do it. And he came back and he was like, oh my God, I'm so
It
sorry.
was terrible.
And I was like, he says, I lasted 45 minutes. And I was like, yeah. And you wanting to walk your dog 4 miles?
Shame, man. A
But
lot of
but they,
owners have also suffered injuries themselves, and that
exactly.
helps
So
them understand. Like chronic back pain is like,
huge.
how many people don't have back pain
Mm-hmm.
because we all sit at the desk all day. So it's
Yep.
it's it's nice to be able to get them to understand from their own personal experience. I know I have a horse trainer who, like, she will take your profession, so she chats to you first and understands what you do, and then she'll use your profession to try and like get you to understand what it is that you're doing with your horse, right? So
And that's
so I like
100%
that
right.
she,
Yeah.
yeah, makes it very personal and individual to you so that you can have that frame of reference to understand. And that's for sure something we could do more with our owners. I like it.
Mm-hmm. Yep.
I love this comment. Michele, your talk is a deja vu of my last client owner today, right down to the HEU harness and rough wear boots, and
Yep.
talking about my own personal rehab. What the?
But it's really true. Like, make it, we try to, and I know we don't have much time, but one of the things we've got to remember is, we know what we know. They don't
Mm,
know anything of what we know. So look, they're already coming to you because you're a professional. So
mm.
they know you're smart. They know you know your stuff. You don't have to
Prove
keep showing
yourself.
it over and over
Mm,
again. Okay. Like, I very seldom call myself doctor anybody, because I know I'm a
mm,
doctor. I've got tons of letters behind my name. Who cares? It doesn't matter. It's how that person's experience with you
mm,
ends. So if
mm,
you can make it so that they're like, oh my gosh, they were so personable. They completely got what I was going through. Like, they went there. They didn't give me false hope. They didn't give me bad information. They made
mm,
it so that I could understand. That person already is walking away feeling empowered about their dog's situation. That's part of our
mm,
job. That is one of the biggest parts of our job, is making our owners empowered. One, so that they will follow this through, so they have an understanding of what we're doing and why. They don't need to know where the iliocostalis muscle is. That's my job. They don't need to
mm.
know, but they need to know what the puzzle pieces are, what the picture looks like, and allow them to be part of that process, even as
Mm,
an onlooker or as somebody who's just a helper,
mm,
because they're the ones that are with their animals all the time. It's our
mm,
job to be better as practitioners to make them understand the whole procedure, functional,
mm,
structural, pain, all of that sort of stuff, and to get to that place where we, okay, cool, great. I get it. I'm on board. This is my plan. I have a plan. Great, let's go with it. And they walk away feeling
mm.
so much better.
Yeah, agreed. We need to, yeah, we need to address our owners more. Like I'm an equine person, so we don't often have owners, right? And it's one of the more stressful things for me about practicing with small animals is that you have an owner that you need to be effectively communicating with. So I think that this is a really good subject for us to explore, and I actually think that we need to get like a whole bunch of analogies on this Facebook group so that we can like use them.
Mm-hmm.
Because I
Well,
wouldn't have thought of
yeah.
that garden hose one. That's brilliant.
Oh yeah, and you know, really, everybody's got a hose, right? Like you don't have to be a rock star, and
Yeah,
we all know what happens when you get a kink in a hose pipe. It's so
yeah,
annoying. But, and you know, with your equine owners, one of the things that I used to do all the time, honestly, and it made such a difference, is I would initially, before cell phones were advanced, I would just send them a client communication list and go, hey, this is what I'm finding. This is why,
mm,
like, do this. FaceTime is super helpful. WhatsApp video. You guys can
yeah,
take a voice message. And owners really appreciate the fact that you
yeah,
care and
yeah.
that you are meeting them where they're at and being able to communicate on an effective level with them and make their animal better. They know you're the professional. You don't have to keep hounding that. Like,
Mm,
yes, we
mm,
know. Yes, you're a vet. Yes, you're a Cara. Yes, you're a. We get it. We get it. Like, it gets boring. Nobody
yeah,
cares. Make it
yeah.
so that it's effective in their lives. Like, that's what they're looking
Mm,
for. They're looking for advice. They're looking for leadership. They're looking for
mm,
reassurance. You need to be that for all of them.
mm, mm. I love that. I think, guys, we've run out of time. So I have to say thank you so much, Michele.
You're
If you
welcome.
hear the beeping in the background here, it's my power's out. We have load shedding.
Oh my gosh, that's terrible.
South Africa.
Yeah.
So, yeah, thank you. This has been a really great conversation, and we're going to
Yeah.
have another one on the Equine platform where we're looking specifically at these relationships in horses, and then we can chat a little bit about also like overcoming those communication hurdles with the owners and getting them to understand as well.
I'll give you some more
Um,
analogies.
Yay! I want a list, like I want to write down a list. It's about my internet's about to die. So
Okay,
bye
cool.
guys.
Bye.